All right, today we're diving deep into one of the most intense exams a surgeon will ever face, the consultant surgery viva. You know, this isn't just about what's in the textbooks. It's all about how you perform when the pressure is cranked all the way up. So let's break down how to absolutely nail it.
Think about it. This is so much more than a test. It's basically a simulated crisis where every single decision, every word you say is being watched. They're testing your knowledge, sure, but also your judgment and how you hold it together. I mean, for a lot of people, their whole career can pivot on this one conversation. So how in the world do you conquer a challenge like this? Well, the secret, it's all about getting inside the examiner's head. And lucky for us, they actually give us a pretty clear roadmap.
Okay, take a look at this. This right here is the examiner's checklist. It's literally the script they're following. It shows every single point you have to hit, from the first assessment to post-op care. It even highlights the big mistakes that will get you an automatic fail. Our goal here is to show you how to get a clearly pass next to every single one of these items.
All right, game time. The scenario starts now. I'll play the part of the examiner, and we'll walk through what a top-notch candidate would say. Here's the setup. A 20-year-old man is in a high-speed car crash. You're the trauma team leader. What do you do?
The very first words out of the candidate's mouth are so important. You have to immediately show that you have a safe, structured plan. The perfect response? Something like this. As the trauma team leader, my first step is to start a systematic primary survey based on ATLS principles. That sentence alone tells the examiner you're methodical and you know what you're doing.
And this right here, this is the absolute cornerstone of trauma. You have to say these steps in this order: airway with C-spine control, breathing, circulation, disability, and exposure. And listen, this isn't just a list to memorize, it's a sequence that saves lives. An examiner will be listening very closely to see if you remember to say C-spine precaution. That's a super common and critical mistake to make.
Okay, so the examiner gives you the first set of vitals. The patient is talking, but he's confused. His blood pressure is 90/60, heart rate is 120, and his GCS is 13. A great candidate hears this and immediately puts the pieces together. Got it. Based on that tachycardia and hypotension, I'm working under the assumption this is class 3 hemorrhagic shock until we can prove otherwise.
Now you have to act on that diagnosis, right? The correct response is a series of quick, confident commands. Okay, I need 2 large bore IVs now, start crystalloid resuscitation, and let's activate the massive transfusion protocol. At the same time, I'm doing a fast scan to find the bleeding, and once he's a bit more stable, we'll do a log roll to finish the primary survey. Boom, boom, boom. Every one of those is a tick in the pass column on the examiner sheet.
So you've handled the initial part really well, but the exam is far from over. The examiner is about to throw a curveball at you to really test your judgment under fire. This is where a lot of candidates stumble. It's a real moment of truth.
So here's the twist. The examiner says, after you've resuscitated him, the patient's vitals get better, and you decide to take him for a pan-CT scan. But just as you're getting ready to move him, his pressure drops again to 90/50, and he's getting agitated. What do you do right now?
This is, without a doubt, the most important decision in the entire scenario. And the right answer isn't some complex medical procedure, it's a command. The candidate has to say, with zero hesitation, I'm aborting the trip to the CT scanner. An unstable patient does not go to the scanner. That right there is a fundamental rule, and it is a clear pass or fail moment. A candidate who's passing will then lay out the new plan just like this. My number one priority is to restart resuscitation with blood products. I'm going to immediately rerun my ABCs. His agitation and dropping GCS tell me we need to secure his airway, so he's getting intubated. And the next stop for this patient, the only stop, is the operating room. That response just screams safe, sound clinical judgment.
Okay, we've made it to the operating room. Now the examiner is going to switch gears a bit and test your actual surgical knowledge. The question is simple. You're in the OR. Tell me your plan.
Your answer here has to be precise. I'm performing an exploratory laparotomy. I'll make a long midline incision all the way from the xiphoid process down to the pubic symphysis. Why? Because that approach gives me the fastest entry and the best possible view to find and control whatever's bleeding.
The examiner then tells you what you find. You open the abdomen, and you see about 1 liter of blood and a grade 3 splenic lacer that's actively bleeding. A good response prioritizes control. Okay, first thing I'm doing is packing all 4 quadrants of the abdomen. That gives us temporary control of the bleeding and buys the anesthesiast time to catch up. Once we're hemodynamically stable, I'll carefully remove the packs one by one to find the source. With these findings, I'm moving forward with a splenectomy.
Now they want to hear the technique. A consultant-level answer needs to be crystal clear. First, I'll mobilize the spleen by taking down the splenocholic and splenorenal ligaments. That lets me bring the spleen towards the middle of the field. Next, I'll very carefully dissect out and individually tie off the splenic artery and vein right at the hilum. And all through this, I'm going to be hyper-aware of the tail of the pancreas to make sure I don't injure it. That kind of detail shows you're not just reciting steps, you've actually thought through the operation.
So, the surgery went great, patient's in the ICU recovering, but you're not done yet. A good viva will always test how you manage complications after the surgery is over.
So here's the last little test from the examiner. It's post-op day 3. Patient is doing fine, but the drain we left in the upper left quadrant is putting out 120 milliliters of clear, serous-looking fluid. What's at the top of your differential diagnosis?
Anyone with some experience should recognize this classic picture. This question is all about testing your diagnostic process, seeing how you think.
A really solid candidate will give a logical, step-by-step answer. Well, given where we operated, my number one concern is a pancreatic leak from an injury to the tail of the pancreas during surgery. To confirm it, I'd send a sample of that drain fluid to the lab to check the amylase level. And just to be thorough, I'd also check bilirubin and creatinine to rule out a bile or urinary leak. That is the exact, comprehensive answer the examiner is hoping to hear. And just like that, you've successfully navigated the entire case, from the moment the patient hit the door all the way through a post-op complication. So let's just quickly recap the key moments that earned a clear pass on that checklist.
This really lays it all out, doesn't it? The path to passing versus the path to failing. The passing candidate was always systematic, always put patient safety first, and thought logically through the problems. The failing candidate? They might rush, forget something crucial like C-spine control, or make that really dangerous call to take an unstable patient to the CT scanner. The whole thing can really boil down to just one or two of these key decisions.
And the final verdict is a clear pass. As you can see from the notes, the examiner wrote good performance. By really understanding how the exam works and what the examiner is looking for, the candidates showed they had the competence, safety, and good judgment you need to be a consultant surgeon.
The consultant viva is a total gauntlet, and a trauma scenario like this one is just one of many you could face. So, you've seen the blueprint for how to ace this case, but what about the next one? What if it's not a trauma, but a complex cancer surgery or a disaster that happens mid-operation? The key, as always, is to just keep preparing.